optimal sequencing of ALK inhibitors is still under investigation. We do know that when patients fail on a second generation inhibitor such as alectinib or brigatinib, that probably over half of the patients have acquired a secondary ALK resistance mutation. So it's an alteration within the ALK tyrosine kinase domain that now interferes with drug binding. And so in fact, these cancers that have acquired an ALK resistance mutation still are ALK dependent or driven by ALK. And so if you have another ALK inhibitor that can actually be active against that mutation, that drug may be very clinically effective. So we've seen in the setting of resistance to second generation inhibitors that a more potent drug like lorlatinib, which was developed to cover all of the known ALK resistance mutations, can be very effective. And in particular, lorlatinib has been shown to be particularly active in patients whose tumors have become resistant due to one of these acquired ALK resistance mutations. And so we do strongly advocate for some form of repeat biopsy when a patient's failing on a second generation ALK inhibitor. We often do tumor biopsies, but actually liquid biopsies or circulating tumor DNA analysis can also be very helpful in identifying an underlying ALK resistance mutation. And that information may then point us toward using a drug like lorlatinib, or in some cases, depending on the exact ALK resistance mutation that's identified, you could actually very carefully choose another second generation inhibitor like ceritinib or brigatinib after alectinib, but I only do that in cases where I know what the resistance mutation is and I know that it should be sensitive to another second generation drug.